Hello, everyone around the world. Thank you for joining the TBPPM webinar today. We welcome everyone from Philippines, Indonesia, Vietnam, from Europe and in Americas region. So it is a good evening, a good morning, and everything at the same time. Thank you for being here with us. We're pleased to see that we had so many people registered, and we are looking forward to a really exciting webinar today. As you can see, we have a full panel of experts today with us, and we will be talking about social health insurances. We've been looking over the last webinar at franchising and looking at strategic purchasing of services and looking at how health financing is linked to TB control and how we can best finance TB care packages. And today we will be specifically looking at that from a social health insurance point of view. And I'm very pleased that we have a expert from country level experience from different places that will give us the practical insights on how this actually works in Indonesia, how does it work in the Philippines, and how does it work in Vietnam. And to kick us off with a more general presentation, we will have a 1-hour webinar. I'm just giving you a few of the details so that you have the logistical background before we dive into the topic. It's a 1-hour webinar. We are recording today. We will also be live streaming on YouTube, so you can view this full recording post the webinar. If you have any questions for those who are listening in, please feel free to use the Q&A. We will be trying to respond during the webinar to your questions and answers. There is a moderated Q&A at the end of this panel, so please feel free at any time to post your questions during the presentations. We will pick them up at the end of this webinar. And with that, I would like to officially give the word to the first presenter, William Wells, who is working as a senior technical advisor at USAID, has a lot of experience in private provider engagement and health system strengthening in many countries around the world. And he's going to lead us into the topic of this social health insurance. So I'm going to share my own screen. So if you can bear with me for a minute to get everything set up.
No problem. Thanks so much, Petra, and thanks everyone for joining. This is a topic very near and dear to my heart, so I appreciate that there's interest from others also. I think it's an important topic for the future. So I want to ask in this presentation a simple question, which is how can TB programs engage with social health insurance efforts? Next slide, please. And we had a great introduction to this topic from the previous webinar in this series, hosted by a number of colleagues from the World Bank, which gave a very comprehensive background, and I recommend that highly for those who are interested. In just one slide, I'm trying to capture a lot of that discussion, which is that there's quite a common shift that's happening in a number of countries. Starting from a more traditional supply side financing that's really based on a kind of top-down planning concept where there's line item budgets, you're really dealing and interacting only with public sector providers. It's somewhat inflexible and it's often not performance driven. So this is a mode of health financing that we're quite familiar with in low to middle income country contexts. As countries move up the hierarchy of income, we're seeing a lot more interest and pursuit of demand side strategic purchasing. And it's demand side because the money follows the client. So instead of the money coming just from the supply side, the client is saying, I want to go to a public provider or a private provider, and the provider then gets paid based on that decision of the client. This is the mode that's in operation in most high-income countries, and there are several ways of doing it, but one of those ways of implementing demand-side purchasing is social health insurance, and that'll be the topic today. So we could expand this slide into a 20-minute presentation by itself, but that's the essential reason we want to talk about social health insurance is because this is a shift that's happening in many countries. Next slide. So this is an example of the three countries we're talking about today, Vietnam, Philippines, and Indonesia. The top graph here is showing the increased percentage of the population that is covered by the social health insurance programs in those countries. The penetration of social health insurance is not quite as high as this graph suggests, because there's still a lot of money flowing through the traditional line item Ministry of Health budgets. But the population coverage is going up, and we assume the money, the percentage of money going to these programs will also continue to go up. The second graph here is an illustration of why we're talking about this in a TBPPM group, a private provider group. So this is for Indonesia, where the empanelment of providers was almost one-to-one for public versus private into the social health insurance program. So when you have a social health insurance program and you empanel private providers in that, you've, for the first time, often got public money going to private providers. And this gives you a very strong ability to then steer the performance of those private providers. And it's a tool that you probably didn't have before the social health insurance. So this is why we want to really stress this in a group that's talking about private provider engagement. Next slide. So where does the social health insurance agency sort of fit in the usual scheme of health financing, where you've got resource mobilization on the left, you've got money coming from a variety of different sources, and it depends on the country which sources are used. And then the pooling is happening at the social health insurance agency, which is then the entity that does the purchasing. It sets the rules for how do you pay for services. And they're purchasing from various different providers. They could be public providers under Ministry of Health, or they could be private. Next slide. There are many different purchasing approaches, and this is listed for reference here. You can pause and read this in detail later. I'm not going to go over each one, but just to say, just to take one example, fee for service is probably a one that many are familiar with, where you're basically paying per consultation, per procedure, per test. The real point of this slide is to say that there are advantages and disadvantages of every single purchasing approach. And so there's no better or perfect approach. You're always going to have to compensate for the disadvantages that go with that method. So for example, fee for service is great for encouraging volume of a certain service, but it can actually encourage overuse. So you need safeguards to mitigate that. Next slide, thanks. And just elaborating on those advantages, disadvantages, those also spill over into TB service delivery. So these various countries have made different decisions on which purchasing approach they want to use. And that has the at least potential for poor outcomes in different ways, depending on that choice. So we heard last time in the last webinar about China's approach. And one of the details there was that the higher payment amounts are made for inpatient versus outpatient care. And the response by hospitals was tended towards over-hospitalization. So then you need a safeguard to say, to keep a check on that. So again, every approach will have its negative outcomes that then you try and manage. We'll hear later about Indonesia, where capitation means that when you get a TB patient at the primary care level, you're still getting the same amount of money. You'd really rather that they go up to the secondary care level. And the secondary care level gets paid per case, so they welcome those people coming up to the hospital level. So that model promotes up referral, and then you have to manage that issue. Next slide. So under insurance, this is what's on this slide is not any sort of golden rule of TB and insurance. It's not a fixed kind of rule in health financing. but I think it's something that we can discuss in the discussion section. The general idea here is that generalized payment design may distort TB care. And we're all kind of devoted to TB and we think TB deserves special attention. But this is, in brief, a case for why TB maybe needs special attention in terms of the purchasing or payment approach. One is that TB is high impact. So it has a big impact in terms of dailies, in terms of economic impact, in terms of public health impact. At the same time, despite that high impact, it's actually rare. So if you're looking at a high burden country, you're really talking 0.25% of the population or less. Compare that to diabetes, where you've got up to 10, 15% of the population, maybe MCH services, a large chunk of the population. So it's a rare situation, and it's also complex. So you get this rare patient coming along and they need a complicated diagnostic algorithm, a long, complicated regimen. So if you put those three factors together, it's rare, it's high impact, but it's complicated. That's an argument for why you may need specific payments to make sure this actually runs well. Next slide. So this is a complicated topic. I've gone rather quickly. This is a paper that's also listed in the webinar description. So if you want to follow up on this, I think covers some of this territory, and it also provides links to other papers in this area. So just a suggestion if you want more on this topic. Next slide. And the final main content slide I want to cover is just stepping back a bit from social health insurance. What in general needs to be financed for TB? And I'm suggesting here three broad sets of functions. The first is the most obvious. It's what we call curative functions. So it's how do you get the diagnostic? How do you get the treatment? And that's a typical area for financing under social health insurance. So it's probably where most of the discussion will be today. But to back that up, you also need two other areas. One is the obvious health system functions like information systems and drug supply systems. But critically, you've got the public health activities. And this is present in many health areas, but particularly important for TB since it's a communicable disease. So you need surveillance and monitoring, you need to track outcomes, you need contact investigation, latent TB treatment, adherence monitoring, tracing patients who are lost to follow-up. These are all things that are needed to control that externality, the public health consequences. But an individual provider left to their own devices may not take on those functions. So these are the activities that are often fulfilled via public-private intermediary functions, and we need financing for them, not just for the curative. Next slide. So in summary, TB is part of the general health system. It typically won't lead a massive health financing reform itself, but will be swept up in any general insurance or payment reform happening in the country. But we need to be proactive as TB people to engage early when these bigger changes are made, and it's easier to actually adapt them to what TB needs. And the second major point is to consciously track the financing of the curative health system and public health tasks. We need to ensure all are taken care of and that there are linkages between them. And that's probably the biggest theme we'll see in the presentations coming from the countries. We need to watch out for focusing too much on the social health insurance curative financing. In that process, you can lose focus on the public health financing. So we need both of those elements in place. So again, I think that's where a lot of the discussion will be. So I really look forward to the examples from the country and then the discussion afterwards. Thank you so much for your attention.
Thank you, William. That was an excellent overview and a really great setting of the scene for listening to the practical activities at the country level. Thank you for going in depth. And as you mentioned, there's on every slide, we could have a separate presentation. So thank you for being so concise and giving a great overview. I would like to, right now, go over to one of the countries, and I'm really pleased that we have a strong panel from Indonesia. We have with us 3 people who are representing the country today. And first of all, I would like to introduce Ibu Yani, Dr. Kalsum Komaryani, who is the head of the Center for Health Financing and Insurance in the Indonesian Ministry of Health. With us also is Prof. Hasbullah, who is the former dean of the School of Public Health and is right now the chief of the party in USAID in Indonesia. And Pa Firdaus Hafiz, who is working at the University of Gadjah Mada and is an expert in health financing and health insurance. So the 3 of them will be bringing us a picture of the situation in Indonesia. And I'm very happy to have Ibu Yani start off and give us a presentation of her expertise and background on what is happening in Indonesia. Ibu Yani, are you ready? I will share my screen and then you can start taking over from me.
Thank you, Petra. Good morning and good evening, everyone. I would like to talk from Indonesian experience on TB health services under the National Health Insurance in Indonesia. Next slide, please. So, health reform has been conducted in Indonesia since the National Health Insurance Scheme has been launched in 2014. The National Health Insurance Scheme, which is called JKN. So under JKN program, the number of people that protected by health insurance is increased. So before JKN, only 45% coverage, and now in September 2020, there are 82% people covered by our JKN. Next slide. So this is the key features of JKN. It is a single payer and compulsory. The source of financing coming from the contribution. There are people there are contributing members and non-contributing members, and the benefit, it is a comprehensive package. It is broad, and we are using the prospective payment, capitation, and the RG payment. Next slide, please. So I will underline on the benefit package in JKN. This program is covering both inpatient and outpatient care, included the TB. And I think some public health program also included in the benefit of JKN. I think about the contribution, because the government, the central government and local government is financing for the poor people, and also there are informal workers and formal workers contributing the pooling of the premium to finance this program. Next slide, please. Of course, because the TB under the JKN program, we can see here that the increase of utilization on TB cases since 2014 until now is going high, and in line with the utilization. I think also the claim is increased. This is in Indonesian million rupiah. So if the cases only around 200 cases, this is the cases at the hospital level, so not included the primary healthcare providers. And I think the claim, it is around more than 1 trillion Indonesian rupiah. Next slide. So based on how to strengthen the strategic purchasing on TB, that's why we need to revisiting the TB payment arrangement and also financing. So on the top of this slide, the yellow colors, this is some services that financed by the government, both central government and local government, and also the donors, because we have ATM program from Global Fund. And the blue one, this is some services that paid by JKN. So those two things should be run together in harmonized, because again, TB is one of the indicators of our 5 years health development plan, and also in our strategic plan in Ministry of Health. So that's why when we hear about the strategic health purchasing, we initiate to introduce the strategic health purchasing on TB and also the maternal neonatal health. So that's why both public health financing and JKN financing should be in line in order to achieve our goal of to reduce the number of TB cases in Indonesia, and how the TB healthcare delivery can be provided in efficient and effective manners. Next slide, please. So some key takeaways that TB is still an endemic prioritized to be eliminated in Indonesia, and the financing is in TB is still a joint financing between JKN and government and also the donors, although many problems still there. And from here, we are thinking about how strategic purchasing arrangement to be conducted to shift treatment to more cost-effective at the primary health level, and also to get better outcome and create stronger incentive for case notification and reporting. I think I will end my presentation. Thank you very much.
Thank you very much, Ibu Yani. That was excellent and a really good overview.
Voice from Petra. So I continue to present the strategic purchasing for tuberculosis. Some of the takeaway already presented by Ibu Yani. So the strategic purchasing is part of health financing activities, collaboration between USAID Indonesia and the Ministry of Health. I'm now chairing as chief of party of these health financing activities. Basically, this activity is a kind of academic work from 2019-2024 to ensure sustainable financing for universal health coverage. We we do assessment and then formulating and digging more revenues for the universal health coverage. When the revenues coming in, and we will ensure that the revenue will be used efficiently and effectively by introducing strategic purchasing. And in addition to that, we are doing analysis to rationalize expenditure and building the capacity that our people can have to ensure sustainable health financing in the health system. So the JKN, as already mentioned, cover comprehensive benefits. The use of managed care technique, which is taken from the US previous experience of closed system, where a member of JKN should go to a certain provider, both public and private, primary care contracted by the JKN, the national insurance, with requirement to have referral. So we use gatekeeping system. Yeah, as Ibu Yani mentioning that currently the TB cases are financed through several programs. Unfortunately, there is still fragmented at this time. The aim of the JKN, as regulated by our health law, is to be financed, to be included in our national health insurance or social insurance, because our national health insurance basically integrating social health insurance scheme and social assistance scheme. We call it PBI in Indonesia. With multiple financing at this time, this is in transition. Some part of the finance by JKN, because that's claimed to JKN, and some still funded by global fund, some with local government, without coordination, and the total cost is unknown. So Hafiz is doing the calculation to estimate how much the total cost for the TB to be efficiently delivered and optimally produce a good outcome. So the proposed strategic purchasing is like this. First, we start with diagnostic at the primary healthcare, both in public and private, using TCM, microscopic, swab and X-ray. Once the case is confirmed that this is TB, pulmonary TB, at this time we start with that, then it will enter to the strategic purchasing mechanism, in which we integrated the payment into having the performance link incentive. We plan to pay per episode of the TB cases to 2 to 3 pay episodes. So we will continue paying the clinics as an initial treatment, the first pay, and then also we have to follow with the sputum check and also follow up the patient, how good the patient's coming on the first pay. And then expectedly the second month we can pay second pay. This is still conditional, can be no second pay, but final pay. We are still in the discussion on this. But at this time, we are thinking that probably after 1 month, there's still lots of follow-up. We have to monitor. In the past, there is no incentive to follow the person who are losing their patient. Yeah? And then upon the completion of the clinical outcome, satisfaction of clinical outcome, patient follow, and some indicators that we agreed are met, then we pay the providers, both public and private, with full amount. So that's the plan. Yeah. So how the current fragmented payment to be integrated. So we are planning to have BPJS or the National Health Insurance Administrator branch. We are currently discussing and preparing for pilot in Medan cities in North Sumatra. So the front purchaser is the BPJS or the JKN, with contracting, verifying payment with providers. By doing that, we expect that performance can be measured and payment to be linked with the performance. So this is the current concept. So this is the timeline. We started last year with the assessment, discussion, building a team to make everything's analyzed, prepare, understands. And this year we are already drafting, negotiating with local government and collecting local data to base our design. And we plan to pilot this strategic purchasing first in Medan cities next year. And then the following year, we will also expand to the second city in Denpasar. Hopefully by 2023, we can find evidence that the overall cost and outcome of the TB program will be conducive to be expanded, to be scaled up to the national level. I think that's for short for the introduction. Maybe Pak Hafiz can add something if necessary. Thank you.
Thank you very much, Prof. Hasbullah. That was an excellent presentation and really good to see that you're taking it forward with also pilot testing, and there's a path forward for further covering the full country. Firdaus, did you want to add a few words?
I think it's fine. I mean, there's a lot of question already, and the question and answer, I'm trying to answer all of them. Thank you.
That's your job, is to answer, Hafiz.
That's great. Thank you for having all the questions. Let's keep them coming. We will definitely pick up some of your questions and we'll address them to the panelists after all the presentations are done. So in the meantime, our panelists will respond to some of your questions in the Q&A. Thank you. Good progress in Indonesia, and really appreciate hearing about this. I would like to now, first of all, apologize for my connection today. I don't know what is happening. Really sorry that I keep dropping out. That's not any intention on the basis of what you're presenting. It's just my bad Wi-Fi. I would like to thank Indonesia and move on to a presentation by Carlos Tan from the Philippines. Carlos is working with USAID as an economist. He has 25 years experience in health policy research and health policy work. He's going to talk to us today about the work that's being done in the Philippines. And I'm very pleased to try and share the screen and hope that this time I will not drop out so that he can actually present the work going on in the Philippines. Carlos, can you see my screen?
Yes, thank you, Petra, and apologies in advance because I too am having connectivity problems with my Wi-Fi, with my internet. But let me proceed with my discussion. Next slide, please, Petra. Let me first preface and provide context. Philippines in the past has experienced what is known as fragmentation of financing. In the case of TB, financing of outpatient TB services is fully taken care of by the DOH in terms of support, in-kind support for drugs and cartridges for diagnostics, and by the local government units, the cities and the municipalities through their financing of facility services, and human resources. So given this situation, one would think that it's just the DOH and the local governments, the towns and municipalities and the cities, which provide TB care or TB financing. But apparently there's also a third entity. It's called the National Health Insurance Program, which is the SHI for the Philippines. It's being managed by PhilHealth. And because of the nature of the redundancy, if you take a look at current records, only around 10% or even less than 10% of notified cases actually avail of benefits provided by the NHIP for TB. In view of this consideration, recent development in the Philippines was the passage of what is known as the Universal Healthcare Law. This law this attempts to address the fragmentation issue, delineates the roles of both the DOH, the National Health Insurance Program, as well as the local government units. So what is this delineation? For the Department of Health, the DOH, it is assigned the financing of what is known as population services. This would be health promotion, health surveillance. So TB screening, for example, would fall under this category. As for the NHIP, PhilHealth is mandated to take charge of financing what is known as the provision of individual services. For TB, this would be TB treatment services. As I said, there's a third player, towns and cities. And as far as the UHC, it does identify who takes care of running the show. That is, who manages the actual effort to, say, eliminate TB and, say, in general, provide services. Next slide, Petra. So under the UHC, health financing and service delivery is integrated under what are known as province-wide and city-wide systems. So under such arrangement, there are two mechanisms that are established for the provision and financing of care. One would be the provider network. This is your network of providers. The other is a special health fund, which is akin to a special trust fund dedicated for the financing of health services. Next slide, please. How does this play in the context of TB elimination? So at present, as I discussed earlier, there is fragmentation as far as financing of TB services. So you would have the DOH providing drugs and other support. You would have, on the other hand, PhilHealth, NHIP through PhilHealth providing case payments for TB services. One opportunity would be to consolidate all of the support under the context of a citywide health system. So in a citywide health system, for example, the city government itself takes the lead in ensuring that the appropriate case finding and case holding is conducted. So there's actually one particular pilot for this effort, although I'm not free to discuss the details because the memorandum of understanding between the DOH, PhilHealth, and the city government has not been perfected. But it actually looks at using alternative case finding and case holding strategies to be able to undertake TB elimination. Next slide, please. So how would this effort look like? In this arrangement, DOH grants are used to support screening and diagnosis. Essentially, the surveillance part, the screening and testing, will be supported by DOH grants. In addition, the National Health Insurance Program through PhilHealth will provide support, say, for the use of chest X-ray for systematic screening. This is for the surveillance and screening aspect. At the same time, the city budget is utilized as a residual payer. So whatever is not funded by both the DOH and by PhilHealth is funded by the city budget. Next slide. So what does implementation look like under such an arrangement? So we would have TB screening and testing. So as I mentioned earlier, this would be partly funded by DOH grants. An example of the DOH grants for this activity would be equipment and to some extent personnel provided by the Department of Health Regional Office for the conduct of systematic screening. At the same time, PhilHealth has a new primary care package, which, as part of its benefits, provides for the conduct of systematic screening using chest X-ray. And at the same time, in addition to the conduct of screening and testing, case holding is supported by the city budget, as well as PhilHealth case payments under what is known as the TB benefit package. In addition, while the situation is in transition in terms of the delineation of what I referred to as population and individual services, the Department of Health is still providing a partial support in terms of TB drugs and diagnostic supplies. One key aspect of this implementation is that funds to be undertaken for TB elimination is consolidated under the Special Health Fund, which I mentioned earlier. So if in other instances, there is external funding support from other partners, say international donors, such funds, when transmitted to the local government, to the city government, would be consolidated in the so-called Special Health Fund. Next slide, Petra. Yes. So to reiterate the specific contributions of the Department of Health and PhilHealth for DOH, in the current pilot, there is a provision of in-kind support. So an example would be a van with a mobile X-ray and a gene expert machine for the diagnosis. At the same time, there is support from the DOH central office in terms of TB drugs, as well as gene expert cartridges. There's a force guide, the TB manual procedures, and other guidelines applicable to universal healthcare implementation. Next slide. Now for PhilHealth, as I mentioned earlier, under the primary care package, PhilHealth will be providing support for the conduct of systematic screening using chest X-ray. Of course, the assumption here is that in the case of that city, the city-run health office will be accredited as a primary care provider. There's also the case payments from the TB outpatient benefit package. So this is a two-part payment provided by PhilHealth. There are fixed amounts for this case payment, but the recipient city government in this case would have the flexibility to utilize the case payment for different elements of the TB services that it provides. And lastly, for inpatients, PhilHealth provides financing for the provision of inpatient care in hospitals. So I think that concludes my presentation for the Philippines.
Thank you so much, Carlos. That was really good to hear, and it's really nice to see the contrast with Indonesia, the similarities, and yes, yet the contrast. Thank you for that presentation and for going into so many details. I would like to quickly proceed, since we have also on our panel today two representatives from the USAID in Vietnam, and Nguyen An is a health systems team lead in the USAID, and with a lot of experience in public health and also in HIV, working within the government. And she's joined by Min Pham, who is the case treatment specialist working on TB and HIV and drug specialization, drug medical assistant therapy in Vietnam. They will be providing a perspective from Vietnam, commenting basically on what we have just heard from Indonesia and the Philippines. So I'd like to ask both of you to, without further ado, just take over from me here. Please go ahead.
Hi, everyone. Can you hear me well? Yeah, so I'm happy to be here in this webinar with my colleagues, Min Pham, to share about Vietnam experience paying TB for social insurance. Actually, that our mission supported the HIV program integrated into health insurance, and we just started with the supporting TB program into health insurance recently. So it's really new start for us. So we don't have much to share as our colleagues in Philippines and Indonesia, but my discussion today will focus on 3 points. The domestic financing landscape for Vietnam, the current health insurance coverage for TB services, and also the implication of the health insurance integration for TB and domestic financing for TB. So I will start first, and then if anything that related very specific technically with TB, I will ask my colleague Ming to add in to this one. So just like briefly about the domestic financing landscape for TB in Vietnam, majority of our domestic financing resource for TB program over the last 10 years is still from the government budget. Either through the recurrent annual budget or earmark funding through the so-called National Targeted Program for TB. But particular note, I want to mention here that majority, 80% of the National Targeted Program for TB was spent to procure TB first-line drug and commodities. I think the second-line drug and other diagnostics tests still be funded by Global Fund. Even health in Vietnam established in 1992, but it's because of the TB program have a national targeted program, so it's not actually being as a loss for TB. The health in Vietnam is regarded as the main method for the public financing for healthcare, and And recently, government Vietnam currently decided to cut off the national targeted program for TB and other diseases. Thus health insurance to be considered as the main resources to fund TB drug, and it's going to be started from 2020 onward. The majority shift is for the TB first line drug to be procured using the health insurance fund instead of a government earmark funding. So the second point for me I want to share is what already in the health insurance coverage package for TB. So you know that 90% of the population is enrolled in health insurance with a full government subsidization for the poor population, but there are still 10% is not enrolled yet in the health insurance. Further, the benefit package for health insurance coverage in Vietnam is also considered generous and comprehensive, with a wide range of the curative services being paid by health insurance, including high technology intervention procedure, rare and expensive drug. And the payment method being used is fee for service for a long time. So that said, I think by legal framework, majority of the TB treatment services are being covered under health insurance, except the TB drug, as it had been covered from the government budget or donor as a second line drug. And also, as I mentioned in the Willie presentation, the health insurance benefit package in Vietnam is on purely the curative services. And so that's why all the preventive related services, including the TB prevention, are currently excluded and need to be covered from the government funding. So the last point, I also want to mention that Vietnam's health insurance is undergoing a lot of reform, that including even the reform, the legal framework, which we consider as the health insurance law. The health insurance law, I think, already effective in 2014, and it is expected to be revised and be in the 2022 as well. And with the direction that maybe the health insurance benefit package can be expanded to cover some of the prevention services. So that's why I think they might not consider as add in some of the TB preventive package services as well. Some superior treatment regimens, or maybe some of the new policy relating to the provider payment reform might be included as well. And I want to emphasize on one important point about the reform for the procurement of the drug in the health insurance. Currently, the government taking the central procurement applied to extensive the health insurance drug, including the TB and HIV, in order to reduce the cost. But I think it's also bring a lot of challenges for HIV program recently, and we also foresee that it's going to be also impact the TB drug in the future if it's going to be using the health insurance fund to cover that procurement. So with that, I think with the very inflexibility of the health insurance regulation and the health insurance reform, and with the limitation of the health insurance curative function coverage of the health insurance scheme, we think even those that the government effort in taking the health insurance as the majority source for the curative function for TB, we still think the TB program in Vietnam still need to be financed from government funding for the key essential prevention, public health, and also non-health insurance coverage population is not under health insurance. So I stop here. I don't know, Ming, do you want to add in some of the key points for the services not being covered by health insurance right now?
Thank you, Kamang. I would like to add only one point. So the funding should come from the government, but not just the central government, but also the local government, because in Vietnam, the province level have a large level of autonomy, and they can provide a lot of domestic funding for TB activity. Thank you.
Thank you.
Thank you both. That's really excellent to hear, and to hear the additional points that in Vietnam are just a little different. I would like to propose to our audience, since we have such an excellent interest in questions and answers, that we go over for 10 minutes longer, and I'm looking forward to William to guide us in the Q&A and moderate the panel. If I could ask all the panel members to put your videos on so that we can have a short panel discussion for the next 10 minutes. Thank you very much. William, go ahead.
Great. Thank you so much, Petra. And thanks for the fantastic presentations. Really, yeah, great diversity, but at the same time, some interesting themes coming together. I just have a few questions. So one is directed towards Indonesia. I don't know, maybe Pak Hafiz, you can start, and please Ibu Yani and Prof. Hasbullah come in too. So the proposal for Indonesia is to call out TB for special provisions in terms of payment arrangements. And that does increase the complexity of the system. But there are existing examples within JKN of identifying particular areas that need special attention, for example, diabetes. Can you comment on that experience where other disease areas, have certain payment approaches, and what can TB learn from that in terms of managing additional complexity? So Pak Hafiz, I don't know if you want to start or if you want to pass to
start first.
Okay, thank you so much, William, for your questions. Yeah, I think it's a great opportunity that we know that TB become one of the priority programs in Indonesia. As we know, we are in the third rank of the world. So I think it's not a special if we put as part of the special arrangement in this case for Indonesia. And we are struggling, and it's become a really challenging, not as like a COVID-19 where they put it as a first priority. Why not TB? That's a big question. And for having the complexity, I think it's this question about how cost effective, how worth it is to put our effort to eliminate TB in this case. So I think that's the answer for this. And what we can learn from others disease also, that we put like diabetes mellitus, blood, hypertension as part of the priority also, because they think that the national health insurance think that there's a lot of expenditures on it, while TB they think it's a rare disease like your presentations, and not much expenditure. But when you look at Ibu Yani presentations, and it goes up and up, almost double every year, then they should realize that this is something really important, including the MDR TB, that the thing that's still low and rare, but actually it's going to grow up. Yeah, that's my comments. Maybe Prof. Hasbullah and Ibu Yani, if you have any more comments.
Yeah, currently we are still developing our payment system. Currently for TB, still fragmented, but for diabetic, for example, we already have additional stimulation at the primary level, what we call it capitation-based performance-based capitation, which is include the promotion and behavioral change such as sport and routine A1C check up every 6 months, for example, to prevent for the more serious disease or more expensive complication in the future. So probably for TB, it is just the beginning, but hopefully we can move forward to be more effective payment or purchasing system of TB. Over.
Great. Thank you so much, Prof. Hezbollah and Pak Hafiz. So moving to the Philippines, Carlos, a couple of questions. So the first is around the Special Health Fund. We've had a brief exchange over this, but I'm still a little bit confused that we have a system where the social health insurance, PhilHealth, is meant to be doing curative, and the Department of Health is meant to be doing the population-based health. But then the funds are pooled. So does the city then become the purchaser and set new purchasing rules? Who's actually the purchaser? Is it still PhilHealth?
It's actually the city. The city
Okay.
government is actually the purchaser. It even runs its healthcare provider network, which is the HCPN, and support to the city maybe in kind or through funds. So in kind means you might have drugs, you might have cartridges, you might have equipment.
So does it mean that every city may have different purchasing rules since they are all purchasers, or are the purchasing rules set more centrally?
The Department of Health has issued a broad guideline, and at present, I'm a part of an implementing partner, a project of USAID that is developing what we may refer to as a Special Health Fund manual, sort of a template. But it has to be customized at the province and at the province-wide and city level. I keep saying province-wide because it's not just cities. There are also the provinces, and that's actually a bigger integration problem. You would have the province and the component municipalities and cities.
Right. So I guess my question is, if we're advocating for TB to be included, and if we're advocating for a particular way of purchasing TB services, is that a city-by-city advocacy approach, or is it more of a single national discussion?
Definitely there is a broad national discussion, but there has to be also, to some extent, province and city level discussions. The reason for this, you would have different motivations among provinces and cities to pursue TB elimination. So my own sense is that the priority should be with the cities. The reason for this is that this is where you find these large congested communities where TB is more likely to be prevalent.
Great. And my final question for you is, so I've seen some of the early experiments in the Philippines with forming these healthcare provider networks prior to the UHC law. At least the ones I saw, it tended to be led by the public sector,
right?
And their comfort level was with other public providers, and so they formed essentially public-only networks.
Right.
They might have said, "Oh, private sector is free to be involved," but there was not a real push there to do that.
Yes.
So from the public side, what is the incentive to actually make a more inclusive, more general provider network that includes public and private?
I think that has to be the impetus coming from the city government. In the past, most of the mechanisms that you've seen, we used to call them PPMDs. These were generally pushed by the Department of Health. Unfortunately, this tends to take a very public character. Let me give you an example. In 2004, the TB benefit package was passed, but it was directed solely at those that satisfy what is known as the TB DOTS requirements. So if you have private providers, it was virtually impossible for these private providers to avail of the TB benefits for their TB patients. So in most cases, what happened was they were told, okay, you can be a referrer for TB services, which they didn't like because they would lose their patients. So the ball's now in the court of the cities to reach out to these private providers. Let's say in the urban poor communities, one target set of providers would be providers who are actually embedded in these communities. The problem is they don't have a network. They don't have the diagnostics. So they have to be linked to a network. So those arrangements have to be developed.
Great, great. Thank you so much, Carlos. So finally, just turning to Vietnam. So Kam An and Min, can you talk a little bit more about how was the process of, as you said, arguing for both the curative side and the more public health, Ministry of Health side? Can you give us a bit more of a qualitative feel of what are your struggles? What are the approaches to actually make sure that both sides of that of TB are covered in that way?
Do you want to answer or you want me to answer?
Can you start first?
So I think we have, we have to do the advocacy at the two approach. So for the first one, I think generally with the revision, the opportunity, the process of revision for health insurance law, we heard that the government of Vietnam actually want to expand the benefit package of the currently curative health insurance package into cover more preventive one. So the discussion is undergoing in country about what consider as the prevention. So at some point the people discuss about something immunizations. Some people are talking about the screening tests, or I think that the like PMTCT preventive mother to child transmission as well. So just give some example of that. So we found that is an opportunity, and you see that the timeline for the health insurance law revision is about 2022, which means that from now on, even that they already have a draft of the version, some of the general language on the preventive services, which may also cover the TB preventive one. I'm still working with the HIV program in order to trying to make some of the HIV related preventive services into the health insurance law, even though we saw it is very, I think, narrow, and it's maybe window, and also the rare opportunity, and also maybe it's just not yet up to the level that we expect. For example, the detail what services to be included. The second point is the government, the government actually now, I think, eliminate the national targeted program, not only for TB, but also for other diseases. So they don't have a national health priority program, but the direction is trying to incorporate into the provincial development and social development programs at the provincial level. When it's integrated into the broader sector, we found that it's I myself may see it's really a rare opportunity in order for us to really monitor how much is really will be spent on health first, and how much the spend will be in the priority programs, for example, TB or HIV or others. But we still have a legal framework of having one important legal article saying about like 30% of the general government budget should go for health, should go for the public health, which is like more preventive areas. So for me, like opportunities in order to really advocate, to use the really, I think, make use of the whether like there's sufficient 30% of that health expenditures really go for prevention of public health, and how much of those is being prioritized to the key areas of the with high burden of diseases such as TB. So these are those things that we need to consider at the same time. Ning, do I want to add any more?
No, I think you cover everything.
Great. Well, thank you so much. I think there's we could discuss this for another hour, but I think there's some really interesting parallels between the three countries. All three are really aggressively adopting social health insurance, but it's a long process. It's always a long process in any country. The population coverage gradually creeps up, the service coverage gradually creeps up, and there's a lot of learning along the way in terms of the purchasing approach. But I think there are definite parallels here that each country is trying to decide where the curative part goes, where the public health part goes, and to be clear on that, and then to coordinate them. So that, I think, is an area that we can continue this conversation in, particularly since the three countries are all in the same region, and lots of lessons to learn here. So thank you very much to the presenters. Petra, do you want to make any final comments?
Yes, no, I'm very pleased. Thank you. This was a very rich discussion and some excellent learning from each of the countries, and lots of challenges that it's good to hear how you are addressing them. So thank you for bringing all these points forward. And I would like to thank the panelists. I would like to thank the audience for a very engaged asking many different questions. You've seen that several of the questions have been answered already, but we will take some of the questions forward to future webinars, and we might get back to some of the panelists to put a Q&A together for everyone to view afterwards. So thank you again, everyone. This video will be is recorded and will be live later today, so that anyone who wants to see the presentations, you can download them, you can view the full webinar again. And I'm going to launch a little poll, so to get your feedback, it would be great if you can just give us your thoughts. And with that, I would like to say goodbye to everyone who is watching today. Panelists, thank you again very much for your time and for your excellent point of views. And we will be following up with you. Looking forward to a next webinar. Thanks, everyone. Goodbye.
Thank you. Bye-bye.